In this lecture, we will review hypersensitivity reactions from a clinical perspective. Hypersensitivity is an immune response that exceeds normal host defense and causes tissue injury. In practice, it appears as allergy, drug reactions, autoimmune disease, vasculitis, and transplant rejection. The classic framework divides reactions into type 1 through type 4. Some clinicians also describe receptor-mediated disease as type 5. The practical task is to distinguish IgE and mast cells, IgG or IgM antibodies, immune complexes, T lymphocytes, and receptor-directed autoantibodies. During initial exposure, antigen presentation leads to Th2 polarization. IL-4 and IL-13 drive B-cell class switching and IgE production. IgE binds Fc-epsilon-Ri on mast cells and basophils. Re-exposure cross-links adjacent IgE molecules and triggers mast cell degranulation. Preformed mediators include histamine, tryptase, and heparin. Newly synthesized mediators include leukotriene C4, D4, and E4, prostaglandin D2, and platelet-activating factor. Important clinical examples are urticaria, angioedema, allergic asthma, allergic rhinitis, food allergy, and anaphylaxis. Type 2 occurs when IgG or IgM binds cell surface antigens. The major mechanisms are complement-mediated lysis, opsonization with phagocytosis, and antibody-dependent cellular cytotoxicity. Examples include autoimmune hemolytic anemia, immune thrombocytopenia, transfusion reactions, Goodpasture syndrome, pemphigus vulgaris, and bullous pemphigoid. Type 3 is driven by antigen-antibody complexes that are not cleared efficiently. They deposit in vessel walls or tissues, activating complement and recruiting neutrophils. Think of SLE, lupus nephritis, post-streptococcal glomerulonephritis, leukocytoclastic vasculitis, IgA vasculitis, and serum sickness. Type 4 is antibody-independent and T-cell mediated. Type EVA involves Th1 cells and macrophage activation. Type IVB involves Th2 cells and eosinophilic inflammation. Type IVC is cytotoxic T-cell driven, and type IVD involves T-cells plus neutrophils. Examples include allergic contact dermatitis, drug eruptions, DRESS, Stevens-Johnson syndrome, toxic epidermal necrolysis, AGEP, and acute transplant rejection. Type 5 is not part of the original Gell and Coombs classification and is often treated as a subtype of type 2. Graves' disease involves TSH receptor stimulating antibodies, while myasthenia gravis involves acetylcholine receptor antibodies. In dermatology, remember, urticaria and anaphylaxis are type 1, pemphigus and bullous pemphigoid are type 2, palpable purpura and vasculitis suggest type 3, and contact dermatitis plus most severe cutaneous adverse reactions are type 4.